Thank you, dear colleagues and friends. My talking will be about the outcomes and safety recommendation when combining abdominoplasty and BBL. So these are my disclosures. So when to combine the abdominoplasty and BBL, the good indication is such patient who comes to our consultation asking for more curvy and feminine silhouette. And in order to achieve that, we have to flatten her tummy, to snatch her waist, to give her curves in hips for the hourglass shape, and round her buttock. And in order to get that, we have to associate liposuction, fat grafting in hips and buttock, and full tummy tuck or mini tummy tuck, depending on the excess gain and the presence or not of diastasis. So, I will ask to raise your hand in the audience who associate or combine abdominoplasty and BBL at the same time. Okay, not too much. And how to prefer to do lipo and BBL first and then tummy tuck? A second stage? Okay. Okay, it's not an easy question because there are controversies. First, about the outcomes and results. As the American Society of Aesthetic and Plastic Surgery recommend to start with liposuction and BBL first and at least 6 months later to do the abdominoplasty. Why? Because when the patient do abdominoplasty, she has to lay down on her back, resulting in the pressure on the buttock, and that's fat survival. Also for safety reasons, it's well known that BBL has higher fatality rate among cosmetic surgery procedures. So when it's combined with abdominoplasty, the morbidity is higher. Plus, the longer the surgery, the higher the risk of DVT, thrombophlebitis, and also the recovery is longer. But in reality, we are dealing with patients who want quicker result and less downtime because patients want to save money and time. The good news, it's possible to combine them safely and also to achieve optimal results. In my practice, I always ask, like Dr. Fodda, which pictures to know which kind of patient I'm dealing with. In the case, if the patient has high expectation and is not compliant with my postoperative recommendation, I will do it on 2 stages, otherwise I will do it on 1 stage. So, these are the most frequent complications when doing both surgeries, and based on that, we will know, deduct the safety recommendations. Safety starts by a thorough investigation about the medical and surgical history and also by selecting the good patient. To be in safe side, the body mass index be lower than 30, but in my practice I always go to 32 or 33. You have to plan how much fat you will remove. To be safe, it should be less than 10% of the body weight to avoid anemia and hypovolemia. And the surgery must not be longer than 4 hours to avoid DVT and thrombophlebitis. We advise patients to quit smoking because it has issues with the healing and can cause ischemia or necrosis, to stop taking supplements or vitamins because it enhances bleeding, and also oral contraception because it increases the risk of DVT. For the patients coming from abroad, I advise them to put anti-thrombotic socks during the flight. If the flight is longer, also to inject heparin prior to the flight. In case of a doubt, I will ask always ultrasound to rule out any DVT. So this is my protocol before the surgery and must insist on the tranexamic acid. It's known in Tunisia as Hexacid. It's used by vascular surgeon. Since I started using this, I have a drop in the indication for blood transfusion. My protocol is usually 1 gram 30 minutes prior to the surgery. I will add another 1 gram IV in case I extract more than 4 liters of fat. And also, to be safe, you have to master your anatomy. For example, when doing tummy tuck, you have to know that in the yellow area, the flap is vascularized by the intercostal artery. In the red area, in the central part, is vascularized by the perforators of the deep epigastric artery. So my recommendation for residents and young surgeons is to avoid liposuction in the central area to avoid ischemia and necrosis. If it's necessary, you have to trim the fat avoid undermining too laterally to preserve the recti muscle perforators, and avoid also too much tension after skin rejection because it's stretch the vessels, and also the lymphatics. So this is my drawing before doing my tummy tuck. So I draw in green the semi-uranerous area. Laterally to this line, I will do deep and superficial fat liposuction. In the blue area, I will do just deep liposuction to loosen the skin and allow me to pull it down. In the red area, I don't do any liposuction at all. To be safe during the surgery, you have to prevent hypothermia. Why? Because it affects the coagulation factors, and studies has shown that the drop in temperature lower than 33 degrees Celsius reduces by half the activity of coagulation. So how to keep the patient warm? By preheating the patient, warming the IV fluids and the infiltration, controlling the OR temperature. If it's possible to use also warming blanket during and after the surgery. Safety recommendation for infiltration. Usually I mix saline with epinephrine and tranexamic acid. I infiltrate 1 per 1 or 1.5 per 1 to avoid hypovolemia. I usually use blunt cannula and infiltrate slowly and gently to avoid any trauma, bleeding, or even perforation. And I start deep, then superficial, and wait at least 10 minutes to allow the lidocaine to be more effective. So, it's very important to know your anatomical landmarks before doing a BBL, especially for the inferior and superior gluteal artery perforators. Here, to locate the inferior gluteal artery perforators, it's located in the middle, in the line between posterior superior iliac spine and ischial tuberosity. And I draw a line between the posterior superior iliac spine and the great trochanter. I divide it on 3. It's the medial third, where is located the superior gluteal artery perforated. Avoid these areas to avoid fat embolism. I never use, like Dr. Fodda, lower doxyresis because the cannula tend to bend. You can be deep without knowing it and inject in the muscle with the risk of fat embolism. I use only 4 mm straight or curved cannulas. Like here, we start with the anterior hip expansion from the front, from the bow view and front view. And then I will inject the buttocks, always subdermal plane, retrograde, and if it's possible, the ultrasound may help you to avoid injecting in the blood vessels. When I will inject from the buttock crease, I always remove the pillows and inject with the cannula parallel to the operating table to avoid injecting in the muscle. In the case I will do tummy tuck first and liposuction and then flip the patient, I will put the patient in what we call jackknife position to avoid any stretching on my quilt sutures or the suture of the scar. So, safety recommendation for BBL to resume, always use pillows and chest roll. Locate your inferior and superior gluteal artery perforators. I use only closed system to harvest and filter the fat to avoid infection. We use antibiotic, and the new coming is hypochloric acid. It's known in Tunisia acide hypochloreux. It can be mixed with the fat. It has an antimicrobial, antiviral, and antifungal activity. And also use larger cannula, retrograde fashion subcutaneous plane. Avoid large volume to avoid any fat necrosis. Only if you have the opportunity to use expansion vibration lipofilling. Ultrasound may help, like Clarius. Avoid to lower blood pressure when injecting because it may happen fat embolism by vacuum. And always keep an eye on the capnia. It's the first time in case of having fat embolism. When flip the patient, we do liposuction of the tummy in hyperextension to stretch the muscle aponeurosis, especially when the patient has diastasis and the loose muscle aponeurosis. You can easily perforate, especially in the center part, so to avoid any bowel perforation, keep the patient in hyperextension position. I will do deep liposuction in the green area to loosen the skin, allows me to pull it down easily. And always I preserve the scapus fascia at least 3 centimeters above the inguinal ligament to preserve the lower abdominal collectors, so there is less risk of seromas. When I do my tunnel in the middle, I don't go beyond the diastasis to preserve the rectus perforatus as possible. I inject always naropain in the masseter aponeurosis for postoperative pain management. And in the red area that I showed previously, I always trim the fat, subscapal fat, to avoid any ischemia or necrosis. I use always quilt sutures, what we call point de capitonnage, between 12 to 16 points to reduce, to close the dead space, to reduce seromas, and also it has less tension on the scar. So, my recommendation after the surgery is to put the patient on forward position using pillow for BBL to lessen the pressure, so the fat survival will be higher. And I put the drains even in the liposections areas and remove them if it's lower than 20 cc per 24 hours. I use now systematically prednisone for 10 days because it reduces swelling, fibrosis, and nodularity. We have the chance to buy very soon the hyperbaric chamber. I will use it for enhancing blood supply and increase fat survival. I give systematically now Singulair because I notice I have a lot of fibrosis. Singulair is 10 milligram twice per day for 1 month. Lymphatic drainage since day one. In conclusion, when combined, the abdominoplasty and the Brazilian butt lift can create a more proportionate and contoured figure. The abdominoplasty helps creating a flatter, more toned look. BBL, on the other hand, helps to add volume and shape to the buttocks, creating a more curvaceous appearance. Together, they work in harmony to give the patient the ultimate hourglass shape. Thank you for your attention.
Thank you very much, Anas, for this excellent presentation.